Very good afternoon to everybody. Uh, I would like to welcome you all for this academic piece, which is this clinicopathological correlation. This is my honor and privilege to introduce Professor Chandra, who is the clinical discussant today. Professor Chandra is the Professor of Pediatrics, ESIC Medical College, Faridabad, Haryana. Sir worked at Lady Harding Medical College for more than 3 decades. He served as a director of this prestigious institute during 2016 and 2017. Sir has major works in the field of hematology and hemato-oncology, for which he received several accolades and awards. Sir has more than 200 papers and chapters to his credit. So now I would like to invite Professor Chandra to open the discussion.
Discuss this case. Actually, this case appeared very simple at the outset, but if you think that why it has been kept for the CPC, it would mean that probably it is not as that simple as it appears. So, but anyway, I thought let me, initially when the invite came, I thought I would be one of the discussants. So fine, I would participate in this, but then I realized that the initial discussion is from my side. So anyway, I thought let me uh, sort of educate myself further on, and let us see how it goes. This one, yeah, okay. So the history that was given to me is 11-year-old female child, is second in birth order, born out of a non-consanguineous marriage, with the complaints of left-sided neck swelling for 5 months, cough for 3 months, and fever for 1 month. So the swelling is described as acute in onset, gradually increasing in size, non-tender, with no history of redness, pain, or discharge from the swelling. The cough was described as non-expectorating, with no history of hemoptysis, post-tussive vomiting, or any diurnal variation, but has a history of worsening of cough on lying down. Also associated with shortness of breath, again worsening on lying down, with no history of worsening upon exertion. The fever was undocumented, insidious, not associated with chills and rigors, relieved on medication. History of diurnal variation present associated with professed night sweats. There is a history of significant weight loss and approximately 10 kgs in the last 5 months, and there is a history of loss of appetite. There is no history of headache, vomiting, altered behavior, or seizures. So there are no intracranial issues there. No history of abdominal pain, vomiting, or loose stools. No history of rash or joint pain. No history of transfusions being given. No history of facial swelling, dilated or engorged neck veins, or redness of the eyes. Yeah, I think so. So, yeah. So the treatment history was that she attended private hospital, was admitted there for just 4 days, received some antibiotics in view of suspicion of sepsis, and she was referred here. The past history was significant in the form of contact with open case of tuberculosis, though it was 2.5 years back. Family history, born out of non-consanguineous marriage, second in birth order, no history of chronic illness or tuberculosis or malignancy in the family. Socioeconomic, belongs to lower middle socioeconomic class as per modified Kupaswamy scale. Calorie intake is deficient by 27% and protein by 30% in the diet. So with this history, the physical examination that was provided to me was the vitals 92 per minute heart rate, blood pressure 100/74. There is tachypnea in the form of 48 breaths per minute, and in fact heart rate also is slightly higher than normal for a 11-year-old female child. SpO2 was 96 on HFNC. Anthropometry, height was minus 1.9 SD, weight was minus 2.3 SD, BMI was 13.8 kg per meter square. So she was stunted and severely underweight. The general physical examination showed the mild pallor was present, icter, cyanosis and phlegming were absent. There was facial edema, prominent neck veins, and lymphadenopathy was present with multiple level 2 and 3 cervical, upper and middle jugular cervical lymph nodes with maximum size of 5 into 6 centimeter. The other characteristics are not given to me, but in the history they were described that there was no redness or there was no fluctuation there, or there was no discharge from the lymph nodes. Respiratory system, fast breathing, increased work of breathing with use of axillary muscles, mild retraction, subcostal retraction present, trachea shifted to the right, chest expansion also slightly reduced on the left side, auscultation showed air entry reduced on left axillary and infra-axillary infrascapular areas, no adventitious sounds heard. Abdomen showed slight distension, all quadrant moving equally with aspiration, no scars, hernial sides free, no tenderness, liver 4 centimeter, span was 10 centimeter, which appears to be normal for this age. The consistency, etc., is not again described. Spleen was 1 centimeter below costal margin. CVS with slight tachycardia there and muffling of heart sounds were present. CNS was described as normal. So with this, the primary issues in this child appear to be in the presence of superior vena cava syndrome because of the fast breathing and swelling that we have on the face, and the veins being prominent out there and cervical lymph nodes, and there is probably pericardial effusion as evidenced by muffling of the heart sounds. Another important thing is that there is history of contact. So if I was seeing this child the first time, I would tell my resident to quickly work up for lymphorectal malignancy, because one has to act fast in such cases, and also try to rule out tuberculosis etiology because there is a history of contact, and a obvious question will come that can tuberculosis cause superior vena cava syndrome? Yes, there are case reports. In fact, from this department itself in 2010, there is one child of 5-year-old which was microbiologically proven tuberculosis was there in this case of superior vena cava syndrome, and another series from BHU. This was on 18 cases, out of which 2 cases of the 17 cases where the diagnosis was confirmed, 2 cases were of mediastinal lymph node tuberculosis. So that's a known cause. In fact, I think I remember earlier also Dr. Arya had reported a series of SVC syndrome, and few cases in that also they were probably that was abstract in some conference. So the investigations which were given to me, there was anemia 8.5, TLC fairly normal, platelets also normal, LFT is normal, urea creatinine is normal, uric acid, calcium, phosphorus is not provided. Mantoux is 30 millimeters. Viral markers given to me are negative. Gene expert and AFB is negative. Imaging we will discuss, and the biopsies were obtained, which obviously the pathology colleagues will tell. So this was the X-ray provided, and clearly it shows there is mediastinal widening. 50%. As I have outlined there, the mediastinum and compared to this one, and the cardiomegaly as well is there. 65% CT ratio is there. So bilateral costophrenic angles were obliterated. There is superior mediastinal widening, cardiomegaly, and oblique fissure was prominent out there. This is the CT neck and chest, which shows left cervical lymph node mass, and epic mediastinal mass, and pericardial effusion is can be seen here. Within the mass, there is an area of necrosis. Large area of necrosis is otherwise a homogeneous mass. It doesn't appear to be conglomeration of many lymph nodes, and the vessels appear to be normal here. Same thing here, the necrosis is there. The pericardial effusion is best visualized here in this and the cardiac chambers are fine. There is some mass is compressing over this the hard border here. Nothing additional there. So the summary of chest finding is the CT chest finding is mild bilateral pleural effusion, pericardial effusion is there. I think that this, in fact, we can go back and see that again. The pericardium is not thickened, and the pleural thickening is also not there. So it appears that there is blockage of the venous or lymphatic drainage. Therefore, the effusions have occurred, not because of the infiltration by tumor or infective process, whatever is causing this. There is a fibroelectric lesion in the retrocardiac area, and mass in anteromediastinum as dense as the cervical lymph nodes. There is a large area of necrosis indenting the cardiac border and trachea and esophagus, not conglomerated, no calcification, no cystic lesion seen within the mass. So, what is the diagnosis? If you look at the mediastinal masses, and quick net search will tell that 4 T's: thymic, thyroid, teratoma, and terrible lymphoma. These are the 4 important causes. But if we categorize on the basis of CT attenuation values, so if you look at soft tissue type attenuation, thymic, thyroid, lymphoma, teratoma, infections, and Castleman disease, these are the common causes, common and some uncommon causes also described. So let us look at where we are. Now first, as I said, with the history of tuberculosis contact, though it is 2.5 years back, but there are multiple sites of lymph nodes, history of contact, positive Mantoux test, pleural and pericardial effusion, SVC, we know that it can occur, necrosis present within the glands, and the fibroelectric pulmonary lesion. But the points against are that there is no rim enhancement, which is usually seen in tuberculous lymphadenopathy, and no calcification and not conglomerated. So this is one possibility in this case. Thyroid in this CT of neck as well as chest, we will come back to this again. There is no neck swelling in the thyroid region. Mediastinal teratoma in children accounts for just about 1 to 5% of mediastinal tumors, and they may present with this type of symptomatology like cough and respiratory distress, but they have heterogeneous opacity, and as we can see here, some calcification, and it's not as homogeneous as we have seen, and the cystic lesions can be there. So associated neck masses can be there. This is one case report in an adolescent from 2008. Thymoma again is something very uncommon in children, though it accounts for 20 to 30% of the mediastinal anti-mediastinal masses in adults. It's extremely rare in children and adolescents, accounts for just less than 1% of the masses. Again, may present with these symptoms. There may be paraneoplastic syndrome, which are not there in at least the whatever description is given to me in the investigation. Though anemia is there, large areas of necrosis are again rare in this. So the rare tumor and the necrosis being rare, this appears to be again a very unlikely thing in this side. Castleman disease, again one of the rare things. I have left lymphoma for the discussion later on. We know that it may be unicentric or multicentric, associated with HHV6 or HIV infection associated, idiopathic, and idiopathic site multicentric Castleman disease. Maybe there is a syndrome called Tefro syndrome, and we'll see that whether that could be a possibility here. It's a fancy diagnosis though. Just about 10 years back, this was described for the first time, and I think in literature some 30-40 cases have been described, and only one adolescent has been described a couple of years back. So there are some diagnostic criteria. We will look at that, and the idiopathic multi-site Castleman disease can present with lymphadenopathy at several sites. Associated liver spleen enlargement may be present. Typical thoracic Castleman disease usually occurs in mediastinum and hilum, not the pleural pericardial involvement may be there in this. So many of the findings which are there in this case can be present, again this being rare. So this is the criteria for Tefro syndrome. Histopath criteria, obviously the biopsy will tell, but the major criteria, 3 out of these 5 are required. So here thrombocytopenia is not there, but effusions are there, fever and organomegaly. These 3 criteria are there. So one can keep this possibility, but again this is being very rare condition and very, very unlikely in this side as one of the first few diagnoses. So coming to the lymphoma as the likely cause here, Hodgkin versus non-Hodgkin. If we look at pediatric mediastinal lymphoma, this is a series from Bangladesh, a recent one. That's why I picked up this. And here 86% were NHL. We all know that they account for almost 3/4 or more than that. And Hodgkin's lymphoma accounting for 10, and one they have listed T lymphoblastic separately, one case. This series from China, they compared the pediatric as well as adult lymphomas, mediastinal lymphomas. Here again, the 75% cases were T lymphoma or T ALL, Hodgkin's accounting for 22%, and this is compared to the adult where the Hodgkin is 23% compared to the NHL being 33%. So not that much of difference as it is in the pediatric age. So NHL usually would have more aggressive course. To me it appears that a 5-month course for an NHL would be slightly longish, but then there are certain types of NHL which have slower course, and I cannot put that as the unlikely condition here. In the present case, contiguous site involvement, fever, weight loss, they all can be present, and necrosis within the glands like this can be there in NHL as well, and in Hodgkin's also I could come across a series of 76 patients where 21% of them had necrotic glands, and this is almost like what we have in our case. The necrosis exactly looking like what we have in our case. So both lymphomas can have the necrosis within the large lymph node mass. So finally, after discussing this, I would put lymphoma because of the chronicity of the course, Hodgkin's as first, NHL as the second, tuberculosis as a cause because the positive Mantoux is there, there is a history also contact. But one thing which worries me is that there is a weight loss of more than 30%. So if it was, she is 23 kgs and 10 kg loss is there, so from 33 she has reduced to in 5 months. So are there other causes for that? I would like to exclude celiac disease, that could be one cause, or maybe during the lockdown period she gained some weight, which many of we all know that as pediatricians we are seeing cases with the overweight and obesity post-COVID. So maybe, and then she lost weight during this illness. So that is one. Second, the HIV, one could have thought HIV with lymphoma could be one cause where there could be rapid weight loss, but the positive Mantoux of 30 millimeter, that takes me slightly away from the diagnosis of HIV, and I am told that the viral markers, I hope that include BC, HIV as we do in our suspected malignancy cases. The next thing I would, because of the weight loss, I would go back to the slides where this slide where there is I don't know, as much I was told by the radiologist, the thyroid mass is not there in the site, and the mass out there. There is a possibility that the rapid weight loss is because of thyrotoxicosis, though there are no other signs. There is mild tachycardia, but this mass could be aberrant thyroid with the goiter and the thyrotoxicosis. But first possibilities of lymphoma and tuberculosis, later on the other diagnosis. So that is where I would rest my case. I don't know how close I am and how far I am hitting even the fifth stump or not. Thank you.
Thank you, sir, for such an insightful and enriching discussion. Now, I would like to invite any thoughts, alternative differential diagnosis, or any comments from this August gathering. Okay. So now that there are no other differential diagnoses, I would like to invite Professor Manisha Jana for her inputs on the radiological aspects.
So, good afternoon. So, as we have already seen the CT, there is mediastinal widening. There is, as Sir rightly said, there was no cervical lymphadenopathy. So, we can see a mediastinal mass with pericardial effusion as well. So, lymphoma will be the first radiological differential diagnosis, and of course TB will be in the DD, and rarer diseases like on the list that those were there, that they will we see much less often, like S1 disease and all, but lymphoma will be the first one here. in the differential diagnosis, mainly because of the presence of lymph nodes in the cervical region and mediastinum, as well as because of the presence of the effusion over here.
Thank you, Dr. Manisha. Now I would like to invite Professor Rachna Seth for her comments and how the case was worked out.
Thank you, sir, for this discussion. So, if we go by the clinical scenario, before we had the investigations, when the child came to us, this was an 11-year-old child, adolescent girl child with 5 months history of fever, cervical adenopathy, and just hepatomegaly, mild anemia, and she just had a spleen bit palpable. But then she was just being observed in the OPD with, of course, you saw the history of motor positivity with a history of contact, which we at 11 years of age and 2.5 years of history of contact, we did, how much relevance to give to that history. So with that background, the clinical possibility, of course, was tuberculosis, but we did keep all other alternate diagnosis at the clinical presentation itself. So the child, while was being followed, of course, TB workup was being done aggressively and gene expert, etc. were being ordered, and while awaiting the reports, the child worsened very fast. Although the history was for 5 months, the tachypnea worsened and the child was frequently visiting our OPD. With that background, we did keep the possibility of lymphoma. In background, in the non-infective, we did not, with the B symptoms also, theoretically you could keep brucellosis, etc. But then with this aggressive nature which the child clinically sort of mounted up with in a few days' time, we were not, because in that also you can have intermittent fever, course can be prolonged, you have B symptoms, weight loss, etc. These are unusual causes, but TB was the main non-malignant differential in our mind. But with this progression, of course, lymphoma was the highest on our cards, sir. But if we look at this, it was more of a peripheral lymphadenopathy with hardly any, just a hepatomegaly, no significant spleen, with a 5-month history, mild anemia. We did keep when the child came as Hodgkin's as the first possibility, but the way the child worsened and non-Hodgkin lymphoma started, being kept as an important differential. And moreover, an examination while the child was being followed up, developed effusions, the heart sounds became often pleural as well as pericardial effusions came up. So with that, of course, NHL became an important differential. Again, as you rightly point out, NHL is the course is quite aggressive. But yes, we do know that the other varieties of like anaplastic or the TLBL variants could have an indolent course and we could have a slightly prolonged course. So this was our main differential. Of course, we had the privilege, we had discussed the images, so we did not keep the thymic disorders and Castleman disease because we had already discussed with our radiologists. So in the yeah. So in exactly, sir. So this so with that, with keeping that, we went straight away went ahead with the lymph node biopsy because meanwhile we did have the reports of tuberculosis being rolled out, and the child went into florid SMS and needed a admission on an urgent basis. So it was in frank SMS when we admitted, and we went ahead with the lymph node biopsy, which was the gold standard. So that is how we approached our case. Thank you.
Thank you, ma'am, for your inputs. So the pathology journey started with the core biopsy after so much brainstorming. We received two tissue cores, which were 2 and 0.2 centimeter in length. The microscopic examination showed diffuse effacement of the lymph nodal architecture with presence of large atypical pleomorphic cells with abundant cytoplasm, pleomorphic nuclei with distinct to prominent nuclei. There were several donut type cells and hallmark cells as well. We proceeded with the immunohistochemistry. The neoplastic cells showed membranous and Golgi's zone positivity for CD30. There was cytoplasmic granular positivity for ALK, and the cells were positive for CD4. So summarizing the immunohistochemical findings, the positive stains were CD30, CD4 and ALK1. while negative were CD20, CD3, and FAX5. So based on the histomorphological and immunohistochemical findings, the diagnosis of ALK positive anaplastic large cell lymphoma was given. So now a word about anaplastic large cell lymphoma. Anaplastic large cell lymphomas, they are mature T cell lymphomas with large neoplastic lymphoid cells showing abundant cytoplasm, pleomorphic nuclear features, and some hallmark cells, and there is uniform strong expression of CD30. In the current 5th edition of WHO, the 4 types of anaplastic large cell lymphomas are described, 2 of which are systemic and 2 are organ specific. The systemic one are ALK positive, as was this case, and the other is ALK negative. The organ specific are breast implant associated and primary cutaneous areas. The ALK positive anaplastic large cell lymphoma is a CD30 positive mature T cell lymphoma with aberrant expression of ALK protein secondary to rearrangement of ALK gene. It comprises approximately 10 to 15% of the pediatric NHL and approximately 3% of the adult NHL. There is a male predominance, which is 3:1 male-female ratio and a median age of 30 years. It presents as rapidly progressive adenopathy, along with presence of systemic features like fever, night sweat, and weight loss. There is extranodal involvement in approximately 40 to 60% of cases, with common sites being skin, bone and soft tissue, lung, and liver. Central nervous system is rarely involved. As far as ALK gene rearrangement goes, there is fusion of the 3' portion of the ALK chromosome on 2p23 with the 5' portion of a partner gene, which causes constitutive expression of the chimeric oncoprotein and thereby the neoplasm. Almost 20 partner genes involved in ALK rearrangement has been described. The commonest one of which is NPM1, which is present in approximately 80% of the cases. The other second in order is tropomycin 3, which is there in 13%, and rest all 18 partners are together constitute 1%. As far as diagnosis goes, the diagnostic molecular pathology, the role of diagnostic molecular pathology is limited. However, in cases where there is null cell phenotype, there can be molecular test for TCR gene rearrangement to establish T cell origin. Apart from that, there can be quantification of minimal disseminated disease, which is now recognized as a major prognostic factor. On histopathology, the lymph nodes show variable pattern of involvement, including paracortical, sinusoidal, perifollicular, intravascular, or diffuse. In the extranodal sites, tumor cells show infiltrative and diffusely infiltrative pattern. Cases with classical morphology show presence of characteristic hallmark cells, which have eccentrically placed large horseshoe-shaped nuclei with multiple nucleoli. Other classical cells are donut cells and embryo cells. The morphological variant of ALK positive ALCL are common pattern, small cell pattern, lymphohistiocytic pattern, Hodgkin-like pattern, and composite pattern. Bone marrow shows small clusters of neoplastic cells infiltrating in an interstitial pattern. That's why, because of this interstitial pattern, these are often missed, and bone marrow involvement as far as morphology only goes is shown in 10 to 14% of cases, and with IHC it has been shown in 40%. On immunophenotype, the cells are CD30 strong and uniform positivity in the membranous and Golgi area. There is ALK staining. In NPM1 translocation, the ALK stain is nuclear, cytoplasmic, and nucleolar, while with other translocation, it is cytoplasmic and membranous. There is frequent loss of T cell associated antigen. and CD3 being negative in more than 75% of the cases, as was the case in this particular index case. CD2 and 4 are most commonly expressed, 40 to 70%. CD45 and CD45 row loss is commonly seen, and CD8 is almost always absent in ALK positive ALCL. It is present in ALK negative, but is almost always absent in ALK positive ALCL. Occasional cases may show aberrant epithelial markers like EMA, cytokeratin, and myeloid markers like CD13 and CD33. However, EBV is always negative. So on morphology, there may be non-hematopoietic differentials and hematopoietic. The non-hematopoietic would include a metastatic carcinoma, however, that would be extremely rare in pediatric age group. The pitfalls being the sinusoidal pattern of invasion of ALCL, there is frequent loss of CD45 and expression of EMA and pan-CK. However, the differentiating features are CD30 positivity of ALCL, ALK positivity of ALK positive ALCL, and absence of diffuse pancytokeratin. Metastatic melanoma again is a differential. However, CD30 positivity, ALK positivity, and absence of melanin and other melanocytic markers will help reach the correct diagnosis. The hematopoietic malignancies which are differential may be plasmablastic lymphoma or ALK positive histiocytosis, and in some cases Hodgkin's lymphoma as well, especially the confluent variant. Now coming on to the prognosis and prediction, the long-term survival rates of ALK positive ALCL are 80% and significantly better than ALK negative one. However, the failure rate is approximately 30%. Progression while receiving the chemotherapy is a poor prognostic factor. CNS involvement, though rare at presentation, however, if present, it is a poor prognostic factor. Leukemic presentation is again rare, and if present, is portends a worse prognosis. Some of the variants like small cell variant, the mixed and lymphohistiocytic variant have poorer prognosis. The presence of minimal disseminated disease, which is determined by very sensitive molecular techniques like digital PCR, which pick up the mutant transcripts, is also a poor predictive marker. The management is anthracycline based regimens like CHOP and ECHOP, and autologous stem cell transplantation after salvage chemotherapy can be used in patients with relapsed ALCL. Because of CD30 positivity, which is strong and uniform in these malignancies, CD30 has come up as an attractive target for antibody-based immunotherapy. Brentuximab is an antibody drug which is being used, which is conjugated with a synthetic antimitotic agent. In November 22, FDA approved brentuximab for pediatric patients with previously untreated high-risk Hodgkin's lymphoma, and there are several in vitro studies of brentuximab being used in ALCL as well. The newer agents like ALK inhibitors are FDA approved for the treatment of ALCL, and with older agents, the relapse rate was 53 to 90%. However, with next generation ALK inhibitors like alectinib and lorlatinib, the response rate is even better. These agents have good CNS penetration and thus are effective in cases with CNS involvement. So, thank you. Now I would like to invite the clinical team for the further course of action and the
Thank you very much, Dr. Ravi. So we had this child who was diagnosed with ALCL. So once we had this diagnosis, we went ahead with detailed counseling and staging workup, metastatic workup was done. So staging as well, this stratification was proceeded with, and chemotherapy was planned for this child. And now I invite my senior resident who was closely involved in managing this case, to just discuss and tell you how we proceeded with this case.
Thank you. So once we made the diagnosis of ALCL, the good part about this disease was there was no involvement of bone marrow and CSF was also cleared. But the bad thing was the mediastinum was involved. And as we know, there are multiple trials which had shown that traditionally mediastinal involvement or visceral involvement in ALCL is regarded as bad prognostic markers. And currently we have come in the era of molecular risk stratification, in which the risk stratification is based on the baseline MDD, that is minimal disseminated disease, and anti-LKM antibodies. But due to logistics, we don't have these available in our institute. So we do this stratification based on the classical involvement of mediastinal involvement at baseline or visceral involvement. We take it as a high risk. And also they have shown a good correlation with MDD. So this child has mediastinal involvement. So this child will come under high risk ALCL. We treat ALCL based on BFM based chemotherapy. And we use ALCL 99 protocol, which most of the center are using as a standard of therapy. The only difference between ALCL 99 and BFM 90 and 95 is that the duration and dose of the duration of methotrexate is lower in cases of when we treat ALCL. That is, we give 3 grams for 3 hours of high dose methotrexate, and we use only single intrathecal methotrexate if CSF is not involved, and there is no role of RT in any of the therapy. So we have started the child on pre-phase for 5 days, followed by ALCL 99 protocol, and we'll do a reassessment after 2 cycles. Now, only one thing is the child is a high-risk ALCL, so we have 2-3 options that we can add to ALCL 99 therapy. That is a weekly vinblastine or a crizotinib or brentuximab. So I'll just speak briefly on these 3 agents. The ALCL 99 with vinblastine weekly has actually not shown to be very effective in ALCL trials, although it has shown to delay the relapse. That is, the 1-year EFS was 91% against the arm which was not used. They had around 73% of event-free survival. But at 2 years, the event-free survival was exactly equal in both the arms. So the long-term event-free survival is not better when we are using vinblastine. So we are currently not using vinblastine because there is no added advantage, and also it adds to the toxicity. Now, as far as crizotinib is concerned, as we know that recently the results of that trial has come, and it has shown a significantly higher rate of thromboembolic event, that is 13 to 14%, and the EFS although has improved to around 78 to 79%. So the cost issues and the thromboembolic event inhibit this use in ALCL. The best agent is a brentuximab that we can obviously use because the event-free survival will increase, and it also had shown that the relapse rate, duration of relapse also increases. The event-free survival increases in brentuximab vedotin. But as we know, the cost is an issue, so we are currently not using brentuximab in this case, and we have gone ahead with the first cycle of ALCL 99, and we'll reassess after 2 cycles. Thank you.
So any other comments? So Mani labeled this child as stage 3 and high risk ALCL. So yes, sir. It's a rare, and it also confers a risk, high risk stratification to the disease.
But from the clinician's point of view, the proteins, the one 13 generally was one would expect this to be in lymphoma is negative, false negative. So that is one. And second, in lymphoma, how much weight loss do you see? That is regarded as more than 10%, but I said on extra cancer related asphyxia, that it's not described in where 30% weight loss described. I don't know whether it was really documented or one should think of another substitutions.
You are right what you are saying, because we generally take it this 10% as cutoff. The B symptom complex definitely puts it as 10%, which is also more defined for Hodgkin's, but they do use this connotation for the anaplastic variants also. But generally it is only 10%. And in fact, we expect a fall. In fact, the weight gain is expected due to fluid, etc. The weight fall is generally not expected. This child did have, and whatever was documented, we had to project that. So this was what a finding was. So,
I think because I brought in this serial thing, If you look at lymphoma, we all know that there is a risk of surprisingly cases over diagnosed senior when we are looking for say in lymphoma cases we just look at whether it is severe or not. So some 60 years age patients have been diagnosed.
If I'm
I
correct,
don't know whether we should make a policy that all now the diagnostics of severe and potential disease to do a severe test.
And so even gastrointestinal involvement with anaplastic also lymphoma is also known. So that is also, we actually didn't work up for that, whether there was some involvement in that respect also, that also needs to be thought of. Sure. Once you highlighted this, I think that also could be a possibility. So I request Dr. Kabra to, so do you want to make your comments? And also with the multiple positivity, what would be your comments on this?
Very evident from the case that child has a ESC and necrosis. So we need to say whether it is incidental and occasional or both these things are. The thing is that if there is a history of complex necrosis and on the side, whether you are treating it as a TB infection versus TB disease. So this is really challenging. That we even situation if ESC positive and not planning for high stress. So this is really challenging that if in such a situation that you should only recognize or video could take. So it is difficult here. I hope that pathologists were able to see, because problem is that there may be a malignancy in some of the nodes. And wherever there is a necrosis, there is a necrosis which are able to have access to the one is that it possibly will make a simple diagnosis, but here it is a complex whether it is incidental and you are right, sir, that if there is a lymphoma, they is more likely to be a partially negative ESC rather than a positive.
It was also, we needed to put the child on steroids because the child was bursting very fast. And so this dilemma needed to be sorted out very fast, that whether it is active disease, active tuberculosis versus the lymphomatosis involvement. Pathology helped us sort this out. Yeah. No, it was discussed, there was no evidence.
Because the chances are that the mass of tuberculosis and ALCL is very unlikely. But there could be a certain focus in the lung. Very unlikely patient doesn't have lung.
It's very true, because this child, after this intensive chemotherapy, had a bad episode, prolonged episode of neutropenia, where again the discussions were held in the unit, and active, attempts were made to rule out active tuberculosis again, when the child was readmitted with a bad, febrile neutropenia and chest infection. But somehow we could not prove tuberculosis even in the subsequent admission.
Patient had neck nodes.
Neck nodes, yes, neck nodes, and then TB was, as I'm telling you, in the second attempt, the child was admitted for febrile neutropenia, attempts were made to rule out tuberculosis again. But then somehow we could not prove tuberculosis. No, we did what? We did. We did that one.
There was for the first biopsy would have missed.
So excisional node biopsy in the situation where the child, ideal would be excisional node, but then in a child who's so sick, overt SMS, admitted in a high dependency unit requiring steroids, it is not possible to do a excisional biopsy, although that would be the most advisable thing to do. Nevertheless, even after this therapy, the lymph nodes have settled. After the first cycle, the lymph nodes have or at least the peripheral nodes have settled.
After the initial cycle, the initial phase, the pleural effusion or the pericardial effusion is completely subsiding, then only you should attempt giving hydrospecific. Otherwise, because these are third spaces, it will continue to be there. So most of the time in a clinical practice, we used to select it as 50%. After the patient stabilizes,
So it was the instruction of resident to resident. The anesthetic is not aware that this kind of mass the patient is going to collapse. It will not be. So the best thing is a quality biopsy, and you should never do a yes, sir, you know what happens is the seniors and seniors and then either he's aware or else.
just one last question. It will be normally mentioned there are 10-15% of the vaccines are. What is our incidence?
10 to 14 of all NHS. It is about 8 to 15 is the range generally that you would see in PHC. It mimics also, it is a great mimics. You have very manifestation, very from simple skin involvement to systemic disease. We hardly see, I think, CNS, we have only one case of CNS involvement. I think lately we had, that shall also refer to neurosurgery. The case of CNS involvement. Amongst NHS. Almost similar See, it's a mimic lungs. If we had 2-3 cases, definitely skin we had even immunodeficiency needs to be ruled out. We can have association with HLH also. But then definitely we had these multi-system presentations of VHCL. So we have a great mimic that is one. Lung we had sir. Bronchial we had lungs we had.
So thanks a lot, Professor Chandra, for such an insightful discussion. Thank you, ma'am, for all your help, insightful comments on the case, and all the comments from the audience, which really enriched everybody in this academic